So first of all, thanks very much for inviting me to talk this evening and to talk on abdominal trauma. A wide range of audience, I can see from all the chat coming through and the different people, but a lot of this, I guess, will be fairly hospital-centric, because the kind of stuff that we do with abdominal trauma, apart from that initial, perhaps assisting in stopping hemorrhage, is going to be within a hospital organisation. So what I'm going to try and do is talk a little bit about current management, current thoughts and processes we use, but also to try and give a little insight into why we do what we do, how we do it, and how we control what can be quite difficult situations and control, so we can actually do quite a technical skill while lots of other stuff is going on. So we'll see how far we get with that. Just some straightforward disclosures, both the images and some of the educational grants that I hold. So this is a really old piece of literature. Back 1989, Anderson et al. Produced a paper that said it was looking at post-mortems, and it was said that a third of preventable trauma deaths occur as a result of unrecognized chest and abdominal bleeding. And I think you'd probably say, well, yeah, that was an awful long time ago now, it's 30 odd years. I'm sure that, we're much better. We've got major trauma centers, essentially since 2012, with major trauma networks supporting them. We work as a continuum and chain of care. It must be an awful lot better than that now, because we clearly a lot has advanced in that period of time. But if you look at the 2016 BJS paper by Broe et al., I think you might be quite surprised to see that 39% of mortality is from massive hemorrhage. Now, we think most of our mortality is going to be from, if you've got massive hemorrhage, the mortality is 39%, still incredibly high. So we may be better at actually seeing it, but are we really any better at addressing it? And even if you've got major hemorrhage, a quarter of people who have major hemorrhage die as a result of that major hemorrhage, either directly or subsequently. So I think those are really quite scary figures from a piece of contemporary data from only sort of 5 years ago now. And it does suggest to me that, well, there's been quite a few changes, but perhaps we may not be quite as good as we like to think we are, and then we may still have a lot of room for improvement still. So what we're going to focus on a little bit, and some of this really should be old hat to everybody, is damage control surgery, which has been going around for a number of years, 20, 30 years. People have been talking about and practicing damage control surgery, both within abdominal trauma, where it first started, University of Pennsylvania, into thoracics, into damage control orthopedics, even into emergency general surgery. But also looking and just touching briefly on damage control or hemostatic resuscitation, and the merge of those two things together, which I do think has significantly improved the outcomes on the most severely injured patients. So what do you mean, just touching briefly, I'm sure everyone's aware of this, what do we mean by damage control resuscitation? Well, back in the day, we used to put 2 large IV lines in and give 2 liters of normally warm crystalloid pretty quickly, and we thought that was resuscitating the patient. And now we just wouldn't do that. We're now looking at giving blood, FFP and platelets, as everyone's aware, and ideally in a 1-to-1 ratio. Essentially replacing whole blood, and in fact a lot of places around the world are using whole blood. I talk to my friends and they're like, oh, have you got whole blood yet? I have experience of that from being overseas, and we're trying to replicate it through the products that we give. But we're giving these things, and everyone should have in the organizations they work, and a lot of now pre-hospital services and helimed services are carrying certainly blood, and some carrying an FFP type substitute, giving in shot packs. So ready-made, ready-to-go shot packs. We minimize crystalloid, and I think that we look back and think, okay, we could have done that 20 years ago an awful lot better, and perhaps we did some harm then. But we also need to manage proactively potassium, calcium, and acidosis. So when I was sort of at junior doctor level, we didn't think we had to give calcium anymore because we weren't transfusing that ratio. But then when we went up to transfusing patients with 10, 20, 30 units of blood, it became a real issue. We do need to proactively manage people's calcium. And then, of course, essentially the new kid on the block, VHA guided resuscitation. Originally old technology, modernized, and made point of care, and actually allow us to control in real time and understand in real time the coagulation, the coagulopathy of the patient, which helps us when we're operating. What do we mean by damage control surgery? Well, you can see on the CT scan here, and there's a couple of very helpful arrows suddenly shooting in and shoot out. So somebody actually saying, look, that's a really important factor. This patient's bleeding to death, and there's a huge retroperitoneal hematoma. But we talk about damage control surgery, we're really talking about controlling hemorrhage. Now, that may be aortic control of the diaphragm, there may be left thoracotomy control to control the aorta. If it's aortic, or it's venous control, we may be infrahepatic, suprahepatic in the pericardium, or even controlling the portal vein and the superior mesenteric artery in and around the pancreas. Lots of techniques to try and arrest hemorrhage in the most rapid way possible. Quite keen though, we go a little bit back onto first principles. The first principle of trauma surgery is the physiology drives the decision making. And that's really key. If a patient is catastrophically unstable, your conservative management, non-operative management of that solid organ injury is just not going to work. On the other hand, despite what the CT says and how many arrows have been put on it to say, well, that's a really bad injury, if they're rock steady and there's no evidence of luminal bounce, non-solid organ injury, you're going to give that and have a really good think about managing that based on the physiology non-operatively. So physiology drives decision making, and I think that's why people who do trauma need to really take a step away from just being a technician surgeon and actually being a clinician and thinking while they're working. One of my colleagues says very much the patient is telling you what to do. Their physiology is driving your decision, and their physiology is saying, I need an operation, or, oh, just slow down a little bit there. We've got a little bit of time to think what we're doing. We don't need an operation just quite at this minute. Another first principle is the management of bleeding is to stop the bleeding. That sounds really, really sensible. But it's amazing how many times you can see back in 1989, we weren't aware of it. And in the 2016 paper, people still die from bleeding. So our aim and objective is to stop the bleeding. And we need to do that as timely as possible. So we need to manage that patient's journey, and certainly they're within the hospital journey, to definitive hemorrhage control. It's really important. So another key message, CT. Now everyone gets a CT because that's just what we do. And we, I think in our unit, we get a lot of pan-CT or CT trauma, so head, neck, chest, abdomen, and pelvis. That seems to be the normal mantra. So it really is for everybody. Every person gets a CT scan. When you look at it and think about it, the resolution of some of the best CT scanners that we've got is down to about 0.5 of a millimeter. So my colleagues saying, well, we can get a roadmap, we can see exactly everything we need to see. This is amazingly huge resolution on a CT scan. It's very helpful. But you could compare that to the resolution of the eyeball. And the resolution of the eyeball is 10 times that of the CT scan. So it's not an answer to say, oh, we're going to get a picture of the CT scan and we'll see what we need. Sometimes one eyeball and actually seeing what the problem is and operating is by far the way to go, and in much higher resolution. However, none of that should stop you getting a CT like this, because it's a really good one to put into talks. It's a Sabatier carving knife that's gone through, actually nicks the spleen through the diaphragm and into the mediastinum. So I mean, I think there is clearly a role for this sort of CT scan. But as you say, well, the key message, if the patient's unstable, if cardiovascularly unstable, or there's evidence of evisceration as bowel on the outside, why are we getting a CT scan? It doesn't make any sense. We're going to have to operate. We're not, in the UK, certainly in the position where we're so resource constrained quite yet, that we're just going to push that bowel back in the abdomen and go, yeah, that's fine. We don't need to do any more. We'll wait and see for them to get peritonitis. So one of the things we have to do a lot of when we're, is talking to colleagues and talking to trainees and actually providing, as people who know me will know, through a mediation service to say, it's okay not to CT. It's okay you didn't get a CT scan on this patient with systolic pressure of 30. Don't worry about it. So it's important we don't delay to theatre in the unstable patient. It's okay not to CT. We know in my institution, if we do a CT scan and the patient goes from CT to theatre, as opposed to going straight to the operating room, there's a difference of 50 minutes. That's a lot of bleeding time. So we need to try and minimize that new CT when it's valuable, or reverse that strategy. Go, stop the bleeding, then go to the CT scan, and if necessary, go back to the operating room. We need to change those priorities. So one of the key messages, the abdominal trauma, the abdomen is a real target-rich environment. And you actually think about it, I was just trying to do some simple, how many organs in the abdomen, how many organs in the chest, but there are at least 3 times more organs in the abdomen than the chest. It's much more complicated. And does also have organs that are very important for physiology, such as the liver. So we're really talking a target-rich environment. So blunt trauma, penetrating trauma is highly likely to do damage to a structure that needs surgery. We know that blunts and penetrating trauma to the chest, a lot of the time we just need a chest drain and we're done. Abdomen, we manage some of the solid organs conservatively, depending on the physiology. The penetrating trauma, yes, there's voguing places not to operate. But we'll talk a little bit more about that in a minute and why that has come to pass. In fact, we'll talk about it now. To beware the rise of non-operative management. Really, we try to balance in our heads the risk of laparotomy, which in fact is really small. We've looked at our data and our complication rates over the last 12 months, and it's incredible, it is very small, versus developing peritonitis. And if you do that and consider blunt and penetrating trauma, okay, solid organ injury without evidence of bowel injury, you have missed bowel injury in 5% of people, 10% of people. If they're physiologically stable, going to do the non-operative management. If they're physiologically unstable, they need surgery. But penetrating trauma, centers have developed have developed paradigms that allow them to say, we're going to manage this, we manage X number of penetrating trauma patients non-operatively. But really, that's driven out of necessity rather than an actual decision not to have to operate on those patients with penetrating trauma. So we'll still work. We have a breach of the peritoneum, they get an operation. If it's equivocal on CT scan, we'll laparoscope them, certainly in the left upper quadrant. We use CT in penetrating trauma if they're stable as our differentiator with about 98% sensitivity for picking up breach of the peritoneum. So I think don't be pulled too far into the management concern non-operative management, and certainly not in penetrating trauma. We know we've had experience that what thought to be innocuous and potentially certainly retroperitoneal trauma, turns out when the patient starts passing flatus through the stab wound in their back, that it's gone through into the retroperitoneal part of the colon, and that's not a good thing. Certainly not to pick up several days later. So we'd really talk through a case, I think, if that's hopefully of some interest for everybody. So when we talk about high-speed motor vehicle crash, so about 6:30, arriving about 6:30 in the emergency department, about a 5:30, 5:40 incident with pre-hospital on scene very quickly and conveyed directly to us, put out as a code red, and we use our code reds are driven really by shock index and a calculation, very simple calculation, calculate the shock index, rather than by mechanism alone or by injury alone. So 6:30 in the morning is put out as a trauma call, as a code red trauma call. Major trauma consultants phone directly and is on their way. And on this, we had some time, so pre-warning, pre-alert. So when he gets to us, his airway's clear. There's no evidence of pneumothorax. The chest seems to be okay. Saturations are low though. His respiratory rate's high. Faint radial pulse, heart rate very tachycardic with an unrecorded or blood pressure. He's alert, but his GCS is 14, and we put a hand on his abdomen. He's got a rigid abdomen. So in this situation, we've got to work out, so, well, we get unrecordable blood pressure, heart rate. We've had that conversation about CTing the unstable patient. Can he survive 45 minutes? Will it help us to delay him by 45, 50 minutes to get in, to get via CT scan, to get all the answers, to get a roadmap, to know what we're doing? Or is then during that time, are they going to deteriorate and get worse? We start massive hemorrhage protocol, 1-to-1-to-1, but we need to stop the bleeding. So 15 minutes later, we're up in the operating room. We've skipped out that CT step. So one of the things we have to do when we get to the operating room, and you've imagined we actually brought the resus, and we talked about this recently in one of our M&M time meetings, where the understanding really is that the operating room and the extension of the resuscitation is where we can do surgical resuscitation. So we've come out of the ED into a place that doesn't mandate us to operate, but it means that we're in a safe space with the right equipment if we need to operate. And our results will always be far, far better in an operating room than they would be in an emergency department if a patient deteriorates very quickly. And they're likely to. Again, we do our best not to intubate the unstable patient who's got torso trauma and non-compressible hemorrhage in the emergency department, because we will lose blood pressure quite often. They may well have complete cardiovascular collapse on induction. But you've brought a whole team of people in. So you've got ED team, the resus team, the theatre team, the anaesthetic team, more anaesthetic team, and the surgical team. So it's really important in that situation to control, to take a handover, to control the crowd, to thin people out who aren't necessary, to task allocate people to do important jobs. We will write we'll have a scribe that writes on one of those whiteboards you can see in the bottom corner that will write timings. So time of arrival, time of induction, time of first cardiac arrest if necessary, time of clamp on if we're doing, we're controlling bleeding from the liver, etc., etc. Second scribe writing and tallying the bloods. So how many units of blood have we had? How many FFP? How many platelets? So that team anesthesia can look up and within seconds, rather than have to look at the floor, go, how many blood packs are there and how many FFP? They can know where we are on numbers and on ratios straight away. Well, once we've got the patient over, the important thing is to do that situational report. So it's a pause moment. So as a surgeon, I would normally lead that by asking anesthesia, the most important people at that time, to set their understanding where they are in their numbers, where they are in the resuscitation, what their plan is, either that plan for induction when we're operating or a different relaxed. Then the theatre team, we've already phoned ahead, what kit have they got, what stuff have they got out, what's their staffing like? Are we double scrubbing, so 2 scrub nurses, or are we more relaxed or only able to single scrub because we've got 2 tables going on at the same time? And then from the surgical perspective, it's really briefing on expectation, plan, and opening that line of communication with everybody. That's the really important thing. And also talking with the surgical team. So we know who's going to do what. These are, we have trainees with us in all these cases. We must train the next generation of people. So who's going to do what and when and how. Then I think it's always good to have a little pause. We've got induction, we've got a catheter in, we've got one person already scrubbed, ready to rock. So that's important. Oh, no. Sorry, I always get a phone call in the middle of things. So anesthetic team ready to go, theatre team ready to go. We pause, scrub, and then we plan ahead for the operation. So we'll say what we think we're doing, what we think we're going to do. Next is to control the controllable. We're going to minimize variability. I find that is a benefit to the theatre team. So what we try to do is use the same equipment every time. So we don't have Mr. A's favorite retractor or Mr. B's favorite tray or Mr. C's something else or these drapes. We try to minimize variability. If we control the controllables, so the theatre team only have to get the same things out. The trainees have to get used to the same on-table retractors each time. Then we assess, we reassess, we plan, and we communicate to what we're going to do. Now, just give me. Sorry about that. Here we go. Good quote. Just this. So no plan of operation extends with any certainty beyond the first contact with the main hostile force. That's a quote from von Moltke from the Prussian army. What I think he was trying to say in this context is no operative plan extends beyond the first contact with audible hemorrhage. So although we might have a plan as what we think we're going to do, it's going to change, and we need to stay flexible to change that plan and not think in rigid lines. So this patient, trauma laparotomy, arterial and venous bleeding in zone 1. That's kind of what it looks like. It's pretty tricky bleeding. So when we talk about audible hemorrhage. Oh, gone back slightly in time. So trauma laparotomy, what do we find? Arterial and venous zone bleeding, splenic laceration, through and through stomach, splenic artery transection, pancreatic transection, and a portal vein injury. Significant bleeding. So we're already thinking, and we're communicating that we're looking at damage control to minimize blood loss. We're hemorrhaging controlling, but it's a damage control case. And we know that really early on when we all recognized it before we actually started. You can see here major vascular injury, just a retrohepatic caval injury. Again, we need to try and control that. And lots of ways that we can control that. One of the simplest way of stopping the bleeding is if you can't name it, ligate it. That's one of the simplest ways. So we don't know what the vessel's called because it's not one we recognize. We can safely tie that off. So hemorrhage control, damage control laparotomy, obviously in the procedure, ligation and consideration of shunt. Major vessels, portal vein, IVC, aorta, we could shunt those and come back and repair them later. So this chap gets splenectomy, ligation of splenic artery, ligation of splenic vein, temporary repair of the portal vein, and damage control procedure with temporary closure. we used a lot of viscoelastic assay. Now we've done some work on it, and we use that to guide our resuscitation. So initially we'll start off on shock packs, but we'll move rapidly from the shock packs onto individualized transfusion practice based on the TEG result, which tells us exactly at that time what the patient requires to assist their coagulation. And it normally runs at least an hour before we have things like the traditional INR, PT, or APTT, or fibrinogen. So we find it very useful, and actually was associated with an improved survival in our trauma torso surgery group. Key message: 10 minutes, 15 minutes after a significant event, pause, sit rep between the anaesthetist and surgeons, reassess, plan ahead. So people, if it's not immediately apparent and we have a trauma trolley within the department that moves around, if we're in a different operating room, which should have all the stuff that we need. But if for some reason we need something else, we need to plan ahead so we're not waiting for it. So it's staying 3 or 4 steps ahead, moving things along that pathway and continuously reappraising that situation. This guy ended up having multiple relocks, completion extended distal pancreatectomy, small bowel, which was edematous with dubious viability, but eventually did very well. It's just a little segue now to we've talked about blunt trauma, but to pick up a little bit on penetrating trauma again. So key message: well, lower chest wounds, including the back, are abdominal. The abdomen is the majority of the torso. The buttock wound, well, you'd be surprised, they're abdominal as well. We've seen an increasing number of buttock stab wounds, targeted stabbings, certainly over lockdown 2, we saw those. The flank wound is also abdominal. Again, target-rich environment, rectus peritoneal or flank, it's an abdominal wound and needs that abdominal approach. You can see here on the CT scan, contrast extravasation, rectum. So again, this is the buttock stab wound is an abdominal, has breached into the abdomen, causing abdominal hemorrhage. So what's the data if we pull together damage control surgery, damage control anesthesia kind of approach? Well, this paper by Don Holcomb and first authored by Brian Cotton really shows by putting this together in pre and post damage control resuscitation that there was statistically improved less blood use, improved physiology when they got through the operating phase, and actually improved 30-day survival. I think we've seen that as well. We improved our survival by introducing a massive hemorrhage in our TEG mediated and a change in product, the way we use transfusion and resuscitation in our severely injured patients. So I guess the question then is, who should do the laparotomy? What I mean, should that be, if you look and see what we just dealt with, we had a vascular injury, a liver pancreas injury, a colonic injury. And I think subspecialization is getting to the point where theoretically we might have 3 or 4 different surgeons all vying for supremacy, because all surgeons have egos, to say who's going to do what first. And that kind of makes things really quite tricky. So we are very much focusing at the moment on training. And in general surgery, I hope there's some general surgeons trainees listening in tonight. We do, from August 2021, the new general surgical curriculum allows 2 options to do major trauma, alongside, most of the time alongside EGS, but a phase 2, which is a sort of middle level of training, and a phase 3, which is last 2 years or so training. So now realization that we need to train people throughout their surgical training in the management of torso trauma operating. We've also got the TIG fellowships, which we have 5 or 6 a year, which are HEE paid for, UK-based fellowships for NTNs. And we have 2 arms of that. One, training the major trauma consultant, into trauma team, being the trauma team leader, running the units from resus to rehabilitation, and then a second arm in the operative or the resuscitative surgery side of things. And then, of course, we've got structured courses like the IAT6 definitive surgical trauma anesthesia course, which continues to evolve, and I'm sure post-pandemic will come back. So I guess questions from me really, or the questions that I have in my mind when I think about trauma care over the last few years is, has the new system, the 2012 put in of major trauma centers, major trauma network, actually improved the outcome of the severely injured torso trauma patient? So we know this, we've seen studies that said we've improved outcome, but how much of that is in the severely injured torso trauma patient? And that's not clear to me at the moment, not university across the UK. We'd probably go as far as say, I'm not sure we have university improved throughout the UK. I guess one of the other things we need to talk about, and the reason why we've got the training changes that we've put in place is, do all centres have immediate access to torso operating consultants who are used to the management of torso injury? And my third question is, are we ready for lockdown release? Which might seem a little bit of a left field statement as a question to throw back to everybody. But are we really ready for lockdown release? And we've seen, we published on ICON collaborative work with our led by our trainees and specifically Alfie Adiyama, that the first lockdown we saw a drop in trauma and then it slowly increased. But Alfie just shared, with this, our lockdown release, post-lockdown one, so lockdown release, we saw in Nottingham a significant increase in trauma calls. So 15% increase in the code red calls, with a change in behavior towards even greater number of young men, risk-taking behavior, high-speed MVC, and a significant increase in penetrating trauma over that time. And a lot of it fueled, certainly in men, by alcohol. So I think one of the questions have we actually changed much over the last 12 years, and do we need to do more to see it? Because I think, and I've talked to colleagues in Birmingham and elsewhere, there is an increase of penetrating trauma, and if it's torso penetrating trauma, it's going to need more intervention than previously. So in summary, I'd say the abdomen is a target-rich environment. If it's anywhere near it, what chest, buttock, back. I've had one that was axilla that also reached the abdomen, but that was a sword injury. Just think abdomen. It's likely to be that. Time to definitive hemorrhage control is key in the unstable patient. Vital coordinated damage control surgery, hemostatic resuscitation, viscoelastic monitoring, use of hemostatics, the management of torso hemorrhage, and communication across the entire team is key to successful outcome. We do need to look at having more people who are trained to do trauma surgically for the torso operating, a little bit, and that's pulled into these new curricular changes. And I do think there are opportunities for further developments and training and improvement in what we do, as well as work to look at, have we actually improved the outcome of this group of patients who are some of the most severely injured that we get. It seems to take a lot of recovering from the abdomen. And finally, if you follow us on Twitter, at East Midlands Major Trauma Centre Twitter account, we put our weekly light bite learning points for everyone to pick up, which come out of our weekly Code Red Teams educational forum. And every week we put out the learning across from what we've learned pre-hospital through to critical care and rehabilitation. And feel free to follow that account. And thank you all very much. My 40 minutes, but thank you all very much for listening.